Hey guys, it's Dr. Cris with International Headache Center, which has transformed to IHaC, where we tailor life action plans with you and to you to live your healthiest, fullest lives. So, I don't know why today I'm a little bit nervous to be on Instagram Live, so I just did some deep breathing, but if you see me stumbling on words, that's probably why. But I got a really cool and good question on Twitter, and so I'm going to read you the question, and that's what we're going to talk about today. So it says, okay, docs of Twitter, friend has no history of migraines, but had nausea, light sensitivity, lightheadedness, tingling, body, and disorientation with a diagnosis of brainstem aura, but no headache. As a migraine sufferer forever, this last thing makes me think her diagnosis should be different. Thoughts? So this is such a good question because it hits on a lot of points that I just want to talk about. And also I'm a nerd because I love talking about headache medicine, but also just general well-being. So taking a few steps back for those of you who haven't heard me talk about migraine in general. So migraine is a neurological condition. And so just like other conditions, and I usually relate it to like things like hypertension or high blood pressure that people can understand or have more knowledge about. So any brain can have a migraine. It does not mean that you have migraine disorder. People who have migraine disorder have a lower threshold for migraine, and so they have recurrent migraine. And so just like any body can have high blood pressure, it doesn't mean that you have a diagnosis of hypertension. Then, that's just something to keep in mind. So there are actually diagnostic criteria for migraine in medicine. Even though a bad headache is a bad headache, it's helpful to know what category of headache does it fall under. And so there's primary headache disorders, which is something that you are genetically predisposed to get. And then with environmental triggers, then you get a phenotype that looks like migraine or tension type headache or whatever the primary headache disorder might be. And then there are secondary headache disorders, meaning that something is underlying the headache, and if you fix that thing, then your headaches will come down. It's not atypical for both primary and secondary headaches to happen in the same person. And so when we talk about migraine, the things that need to happen in order to have a diagnosis of migraine is that you need to have at least 5 attacks, and that's migraine disorder, right? And these attacks, usually in the adult, so this is a little bit different for children, but right now I'm specifically talking about adults. They need to last a minimum 4 hours. Usually they last more, and typically up to 72 hours, but there are people who have consistent, persistent headache. And then you need at least 2 of the following characteristics. And this is where things, I think, get confused from, the doctor's office then to, the general population. To me, criteria for migraine, you have to have either a headache on one side of your head, or it feels like throbbing or pulsating, or it's moderate to severe in intensity, or it's aggravated by movement. And so if you have 2 of those, then it still meets criteria for migraine. So if you have, usually we think of migraine as one side and feeling like pounding, right? But if you have a very bad headache that you get up and it gets worse, then that's also a migraine. And then, so, meeting 2 of those, and then also you have to have either nausea and or vomiting, or light and sound sensitivity. So both of those things. So there are a lot of people who might be walking around with migraine who actually don't know that they have migraine. And just for the record, migraineurs are the most stoic people that I know. And so that's migraine. And then with migraine, it's another umbrella term. You can have migraine with aura, meaning there's neurological symptoms associated, or migraine without aura. And so Migraine with aura, then you meet criteria for the migraine as we just discussed, and then you have different types of aura. And aura can be, the most common one is like a visual scotoma or scintillating light, kind of like flashes of light in your periphery. But there are different types of aura as well, and usually they last 5 to 60 minutes and they precede the headache, although it can happen during the headache as well. And so migraine with brainstem aura, which is what the question alludes to, or the brainstem aura is one of the types of aura. And so in order to meet criteria, and I know I'm talking a lot of technical things, but I think it's helpful to just hear, what the criteria actually are, and that way you can go back and say, okay, well, does this person meet criteria or not? And it can help with the differential diagnosis. So in order to meet criteria for brainstem aura, then you have to have 2 of these, and it's a long list. So dysarthria, meaning trouble with talking, so you sound slurred, sort of like you've been drinking too much. Vertigo, so feeling off balance. Tinnitus is that ringing in your ear, sometimes it's called tinnitus. Diplopia, meaning double vision. Ataxia, so trouble with walking, also seeming like you've drank too much, because this is brainstem and is in the back. It helps with coordination. And sometimes the aura can involve loss of consciousness, which is, your wake centers are back there too. It cannot involve any motor symptoms, meaning you cannot have weakness and then call it migraine with brainstem aura, okay? Because there's a different type of aura called hemiplegic migraine, and that's half your body. Plegia meaning doesn't move. Having talked about what migraine is and isn't, what migraine with aura can be, meaning all the different types of aura, now we go back to this diagnosis. So migraine with brainstem aura in someone who doesn't have a diagnosis of migraine and has never had aura, brainstem aura, presumably before. So migraine with brainstem aura and most of migraine disorders are a diagnosis of exclusion. You can exclude, meaning you can make sure that other things aren't going on, usually by history and physical exam. So a lot of primary headache disorders don't need imaging and don't need labs. This one in particular, especially, I don't know the age of this person, but especially since it's happening for the first time, the first thing that I would want to work up for is, are they having a stroke in the posterior part of their brain, or is this a transient ischemic attack? So basically, what a stroke is not enough blood flow to the brain, and then that tissue dies. What a transient ischemic attack, or a TIA, is you have a blockage of a part of your brain, and then the clot dissipates, moves along, and so the brain is perfused again and doesn't die. But if you've had a TIA, then you're at risk for a stroke. So I would want, if this was my patient, I would want the patient to have imaging of their vessels, so their neck. This could be done through ultrasound or by MRA or CTA in the neck, and then in the brain as well, just to make sure there's not any narrowing anywhere, or something that might lead us to believe that this was secondary to a blood vessel issue that then could be related to stroke. I'd also want to get an echo of the heart and make sure that it's pumping well, that there's no clot sitting there, that there isn't a PFO even. That can help with migraine. That's a patent foramen ovale, so an opening in the middle of the heart from one part to the other. And then I'd want to risk stratify. So just to make sure, because these are stroke-like symptoms, right? What is the cholesterol level? How high or low is the bad cholesterol? Should they be put on a cholesterol medicine to kind of prevent symptoms in the future? Have they gotten tested for diabetes? That sort of thing. Also, the symptoms are a little bit atypical, and I don't know how often from this point on they've been recurring or not, but it might be prudent to look into, is there some other neurological phenomena happening? Seizure can sometimes look a lot like migraine, and this is where kind of your brain starts firing, and it fires abnormally, causing symptoms. You don't have to be shaking to have a seizure. So, was the patient looking with a blank stare or something like that before or after the symptoms. And I don't have all the information, but that's something that could be easily tested for with a routine EEG. So that's where they put the stickies on your head, they test your brain waves and see, is there anything abnormal about that maybe you should be put on seizure medicines for. And then based on imaging and how the patient is doing and the studies that we've talked about, that we can think about other things, especially if this patient was one that presented to the ER, what is their blood pressure doing? Sometimes really low blood pressure or really low sugar can cause neurological symptoms, and you just treat that. And then, like I said, based on the whole story, what are their vitamin levels doing? And especially B12 can cause some tingling and neurological symptoms. And then, is there anything going on with the inner ear? So I do an exam in the office to see whether there's any nystagmus or beating on one side or the other, and kind of see, does this person need a formal evaluation for benign positional vertigo or something else? And so those are the things that I'm thinking about as I hear about this patient off the bat. But here's some food for thought, and just kind of assuming that these things were done, or the bulk of these things were done, and the patient is doing better, and knowing that migraineurs are very stoic, and a lot of patients who think they have regular headache actually do meet criteria for migraine. I wonder if this patient actually does have headaches, just was never labeled as migraine, and that regular headaches, if you already have a decreased threshold to have migraine, and I don't know what was going on in the person's life either, but increased stress or, changes in what they were eating. And when I say stress, I mean both physical and psychological, or what have you. And then it mounted to the first episode of migraine with aura. And so it's important to note that when you have an aura, and so I think what happened if I see this person kind of presenting to the hospital because these are stroke-like symptoms. And so when they present, this could be a stroke mimic. And so they need to do the workup I just discussed, or if it's in the outpatient setting as well, assuming that the symptoms all went away. But then a lot of patients are so scared by the symptoms, they don't remember the headache. Remember, you don't have to have a moderate to severe headache to be diagnosed with migraine. If they had a mild headache afterwards, and I've seen this being in the hospital as a neurologist and being a headache specialist, that people come in as a TIA or stroke, and then it turns out that it was their first presentation of migraine with aura, and actually they've been having headaches all their life. They just thought it was sinus headaches or something else. And so I'd want to get some more information from the history and sit down with this patient and talk about, were you really not having headaches, or have you, did even a mild headache come on afterwards, and see what they thought. Knowing that a lot of patients don't get diagnosed with migraine, that's half the problem, right? Is that there's a delay to diagnosis, and so then there's a delay to treatment. And that also, this could be the first presentation of migraine with aura especially if they had headaches before, but also it could be a new presentation as well. So I want to go back now to the question. And so for those of you who join me later, I'm going to reread. It says, okay, docs of Twitter, friend has no history of migraines, but has nausea, light sensitivity, lightheadedness, tingling body, and disorientation. Diagnosis, brainstem aura, but no headache. So going back to the diagnosis of brainstem aura, so I'm going to just go back and check some boxes. Does this person perhaps meet criteria for brainstem aura, assuming that other things have been excluded? So it says here that they had tingling body and disorientation. So with disorientation, I don't know if that's maybe could go into they were feeling vertigo, and then tingling body, I don't know that goes right. It has to be two. Dysarthria, so trouble speaking or feeling off, ringing in the ears, double vision and trouble walking, and decreased loss of consciousness. And so I don't know if other symptoms were associated with this, but based on the information I'm given, a tingling body and disorientation could be aura, but are not enough to meet criteria unless another symptom is involved. I'll give the disorientation, but tingling body is not brainstem aura. Could be another aura though. Okay, so then let's take a step back and say, could this person, assuming they forgot about a headache they had, or maybe they weren't talking about the headache, which is usually what happens in my clinic. I ask patients to tell me how many headaches they've had, and they'll be like, oh, I only had 5. And then I'm like, really? You've only had 5 headaches? And they're like, well, 5 severe ones, but I have a headache every day, right? So assuming that that's what's happening here, maybe there was a mild headache or they don't remember the headache at the time, then nausea and light sensitivity. So just having the nausea, if there was any kind of headache that's worse with movement, even if it wasn't severe, if it's one-sided and meets the criteria that we've talked about before, could be migrainous in theory. So to put all this together is that it is possible that this could have been a migraine with aura, unless we have more information, maybe not migraine with brainstem aura. And it'd be interesting to follow up and see, were there any headaches, even mild headaches, don't label as migraine, and did they meet any of the other criteria? Because just having nausea tells me a lot. So hopefully that's helpful. I know I talked a lot, but this kind of question is very interesting to me, and so maybe I can follow up and see kind of if there were any other bits of information that might help us make the diagnosis. So that is all I wanted to talk about today. Tomorrow I will be on One Life Radio at 12 p.m. talking about headache medicine. I think that's through iHeartRadio, but I don't know. But anyway, I hope that this is helpful. Once again, Dr. Cris with International Headache Center, which has transformed to IHaC, and we do our best to help tailor life action plans that help you be your best you. So thanks for listening. Bye, guys.